So welcome to Myasthenia gravis. So what is Myasthenia gravis? The hallmark of Myasthenia gravis is muscle weakness that increases during periods of activity and improves after periods of rest. Certain muscles, such as those that control eye and eyelid movement, facial expression, chewing, talking, swallowing, are often, but not always, involved in the disorder. The muscles that control breathing, neck, and extremity movements may also be affected. The etiology of MG. Neuromuscular junctions and the thymus glands are the two areas where MG affects the body. Normally, when impulses travel down the nerve endings release neurotransmitter substance called acetylcholine. Acetylcholine travels from the neuromuscular junction and binds to acetylcholine receptors, which are activated and generate a muscle contractions in voluntary muscles. In myasthenia gravis, a relatively rare autoimmune disorder, antibodies form against acetylcholine nicotinic postsynaptic receptors at the neuromuscular junction of skeletal muscles, which prevents muscle contractions from occurring. These antibodies are produced by the body's own immune system and affects voluntary muscles. If you look at this first image, it shows where the neuromuscular junction is, and specifically the acetylcholine postsynaptic receptors on the muscles, and this is where MG affects the body. The next area where MG affects is the thymus glands. Research believes that the thymus gland, a part of your immune system situated beneath your sternum between your lungs, as you can see in this picture, may trigger or maintain the production of antibodies that block acetylcholine. The thymus is small in healthy adults. However, in some adults with MG, the thymus is abnormally large. Some people with MG also may have tumors of the thymus called thymoma. The relationship between the thymus gland and MG is not yet fully understood. Scientists believe that the thymus gland may give the incorrect instructions to developing immune cells, which causes an autoimmunity and the production of acetylcholine receptor antibodies, as this sets the stage for the attack on the neuromuscular transmission. These are the four types of MG: generalized, ocular, congenital, and transient neonatal. Generalized make up 85 to 90% of patients who developed MG, which is characterized by weakness in the trunk and of all four extremities. Ocular MG makes up 10 to 15% of MG patients and affects ocular motor muscles only. Congenital MG occurs in 10 to 20% of children born to mothers with MG. Congenital MG develops at or shortly after birth and causes generalized symptoms, with onset usually within the first hours of life, with the newborn developing hypotonia, feeding difficulties, a weak cry, facial diplegia, and respiratory difficulties. Transient neonatal MG is a temporary condition that develops in 10 to 20% of infants born to mothers who have MG. Transient neonatal MG is caused by the circulation of the mother's antibodies through the placenta, and it lasts as long as the mother's antibodies remain in the infant. However, it only lasts for a few weeks after birth. Here are the symptoms of MG. Obviously, over here in the image, you can see ptosis, the droopy eyelid, diplopia, which is blurred or double vision, dysarthria, which is slurred speech, dysphagia, difficulty with chewing and swallowing, and then you'll see distal weaknesses in extremities, chronic muscle fatigue. These symptoms can most often be relieved with rest. And the last symptom, the myasthenic crisis, is when it happens in the late course of MG in 3 to 8% of cases, with difficulty breathing, respiratory distress with respiratory failure being a complication. Diagnosis of MG. Obviously, your doctor is going to perform a neurological examination. It's going to look at your reflexes, muscle strength, muscle tone, senses of touch and sight, coordination, and balance. The next one that he would perform is the endorphin test. An injection of the chemical endorphin chloride may result in a sudden but temporary improvement in your muscle strength. This is an indication that you may have MG. Endorphin chloride blocks an enzyme that breaks down acetylcholine, which is the chemical that we talked about that transmits the signals from your nerve endings to your muscle receptor sites, known to happen in MG. The ice pack test looks at ptosis. In this test, the doctor places a bag filled with ice on your eyelid. After 2 minutes, your doctor removes the bag and analyzes your droopy eyelid for signs of improvement. Doctors may conduct this test instead of the endorphin test. Blood analysis. Blood tests may reveal the presence of the abnormal antibodies, and the repetitive nerve stimulation or the nerve conduction test is when doctors apply electrodes to your skin over the muscles to be tested, as it sends small pulses of electricity through the electrodes to measure the nerve's ability to send a signal to your muscle. In order to diagnose MG, doctors will test the nerve many times to see if its ability to send signals worsens with fatigue. The single fiber electromyography, the EMG test, measures the electrical activity traveling between your brain and your muscle. It involves inserting a fine wire electrode through your skin into a muscle test to a single muscle fiber. It seems very invasive. Obviously, a CT and an MRI would be looking for a tumor or other abnormality in your thymus. And the pulmonary function test evaluates your breathing. Treatment. There's many medications. Treatment, even though no tested treatment trials have been reported and no clear consensus exists on treatment strategies, MG is one of the most treatable neurological disorders. Several factors, such as severity and disease progression, should be considered before therapy is initiated or changed. So the first line of defense is medication. The pharmacological therapy includes anticholinesterase medication and immunosuppressive agents such as corticosteroids and the intravenous immune globulin. In the mild form of the disease, the ACHE inhibitors are used and meet the needs of the patients with MG. Most patients are able to determine dosage of their medication to control the disease symptoms, but severe exacerbations can occur in patients with previously well-controlled disease. Most patients with generalized MG require additional immunomodulating therapy. The immunomodulation can be achieved by various medications such as commonly used corticosteroids. Plasmapheresis is also used, which is a plasma exchange. It is believed to act by removing circulating humoral factors, being the anti-acetylcholine antibodies and the immune complexes from the circulation. It is used as an adjunct to other immunomodulatory therapies and as a tool for crisis management, like we would discuss before. Like intravenous immunoglobulin therapy, plasmapheresis is generally reserved for the myasthenic crisis, and improvement is noted in a couple of days, but does not last more than 2 months. A thymectomy is the removal of the thymus. There is no controlled trials thus far to assess the efficacy of thymectomy in MG. However, this procedure has become the standard of care and is indicated for all patients with thymoma, which, remember, that is a tumor on the thymus, and for patients aged 10 to 55 years without thymoma but with generalized MG. The thymectomy has been proposed as the first-line therapy in most patients with generalized MG. Research is underway to determine whether thymectomy combined with prednisone therapy is more beneficial in treating MG than prednisone therapy alone. Prognosis. The prognosis is fairly good, especially with generalized MG, as nearly 90% of MG patients are in remission when treated with the ACHE inhibiting drug initially. With ocular MG, ptosis responds to the ACHE inhibitors as well, and diplopia responds to corticosteroids. As we talked before, the neonatal transient MG, the prognosis is excellent, with the recovery complete within 2 to 4 months of birth. Statistics. The prevalence of myasthenia gravis in the United States is estimated at 14 to 20 per 100,000 of the population, approximately 36,000 to 60,000 cases in the United States. Women are more affected than men. Most common age at the onset is the 2nd and 3rd decades in women, the 7th and 8th decades in men. A 2015 study in acetylcholine receptor antibodies positive Caucasian has demonstrated that there is no specific causal gene for MG. About 3% of the study population had a primary relative with MG, suggesting a small but distinct but not direct genetic influence. And here are my references. Thank you all for listening, and I'll be ready to respond to your questions. Thank you.